Hey everyone, it's Jane McLeod. Today I'm doing something so radical and so amazing. I'm so happy to bring it to you. I'm going live in a nursing department at Grant Regional Hospital in Lancaster, Wisconsin, a five-star hospital. How do we keep our 5-star rating, you say, if we already have it? We put the nursing bundle in place. So for Nurses Week, happy Nurses Week if you're a nurse watching this, I'm going to go live with a fantastic group of nurses that are taking great care of people and really have achieved that greatness by hardwiring and making muscle memory that stuff, that great stuff, that evidence and best practice that we refer to as the nursing bundle. All right, here we go. I'll see you on the flip side. Here I am again. I have the beautiful and wonderful charge nurse, Miss Rhonda.
Yes.
Say the name.
Rhonda, what?
Last name.
Pennycamp.
Pennycamp. Okay.
Sorry.
So, Rhonda Pennycamp.
Yes.
RN. And she is going to demonstrate for all of us how they use their whiteboards.
Yes.
Okay, do you agree with me, Rhonda? Like, this seems old school, but it's important to the patient.
Very much so. I feel like sometimes it can come across as just like monotonous too as we're filling it out, but it definitely, the patient will use it. So it's good. It's beneficial for everybody.
Sure. All right. The lovely Rhonda is situated at a patient whiteboard. Yes. So, Rhonda, when do these get updated every shift? Obviously, you fill it out when your patient gets admitted.
Sure.
But when do they get updated?
So at every shift change that we're doing shift bedside report, we will come in and update it. So with the nurse, who the CNAs are for the shift, we'll make sure that all the information is correct on it. We'll make sure the IV fluids are kind of updated and their activity kind of what they are, if they've advanced or if they go backwards. And then therapy times, we make sure those are updated at least for day shift, so the patient knows when therapy is coming in to help out.
And how do you see that both patients and families use the boards?
Patients and families definitely look at who the nurse is, who their CNAs are. Sometimes they forget who their provider is too, so that's kind of helpful to have up there. And then they definitely look at the therapy times, just so that they can kind of get a schedule of what their day looks like in their head too. And then their pain meds, we kind of update that so they know when their next pain med is due, so they look at that as well.
Okay. Yeah, I just heard the patient John ask Emily, what do I have? What's the agenda for this afternoon?
Yes, absolutely.
Sure. I'm looking at that. I want to know what's next.
Yeah.
So I see, I've never seen this on a whiteboard. You have code status up there.
Yes. Huge.
Is that filled out?
Yes, it's filled out on admission, so that's huge as well. So especially when you're pushing the code button and you have all these people coming in, we can all make sure that we're on the right page with the code status. And also sometimes provider might forget to put the order in of a DNR or full code. So when we do admission, that's a red flag to us to make sure that that's filled out too.
Oh, genius.
So,
yeah, you're right. Okay. Yeah. So what do you hate about these whiteboards?
So we have had patients say that they're not big enough.
Okay.
So a lot of times the bed is not as close, so they can't quite see it as well. I mean, it's a little bit smaller. So I think that's the one major thing is they're not big enough.
Okay.
And sometimes we don't use all of the boxes.
Okay.
So that's kind of they're patient specific a little bit too. So,
okay.
Yeah.
All right, cool. Well, thank you, Rhonda.
Yeah, thank you.
Enjoy your day. Hi, Rhonda.
Hi.
Rhonda is a charge nurse.
Yes.
Right?
Yes.
That's your title?
Yes.
Okay. So likely you've given bedside shift report a few times?
Yes, just a handful.
Yeah, just a handful.
Yeah.
And what would you say that has made the biggest impact to hardwire it? Like where nurses are like, we wouldn't think about doing it anywhere else. Like we just do this. What made it muscle memory for you guys?
I think consistency and starting from going through the same routine as you would for every patient. So your name, DNR, who the doctor is, that kind of thing, starting from the top and kind of going, and then thinking head to toe focused wise. Sure. I guess is how I do it. And then if you don't miss anything, and it's really helpful when the other nurse doesn't interrupt you maybe a little bit too, so you can get through your whole thing, and then if they have additional questions at the end, I think is the main thing.
Sure.
So, yeah.
Do you think the patients love it?
Oh my gosh, absolutely.
Right.
Yes.
These guys were so jacked in
Yes,
there.
they like it because I feel like it makes them feel part of their care too.
Right.
So that's important because they want to feel responsible of their own person and their care in the end. So
yeah. All right.
Yeah.
Anything else you want to add?
No.
Ticks and trips and hacks from Rhonda the charge nurse?
Oh gosh, positive attitude. It's all, it makes a big difference.
For sure,
So,
for sure.
Yeah.
Even if the patient didn't have a great day, there was something great that happened.
Yes, absolutely. You can always find something positive in everything.
All right, thank you.
Okay.
All right, ladies, talk to me. What do you love about bedside shift report? Bedside handoffs.
I love how it helps you not to forget certain things that are maybe on the whiteboard that you wouldn't have written down.
Okay, perfect. What about you, Kirsten?
I like laying eyes on the patient and being able to ask any questions that you may have and see the patient with the questions.
No more the patient's a disaster when you get in the room and they were sunshine and flowers and report, right, sister?
Right, yeah.
Yes, no kidding. So talk to me a little bit about what you see the benefits are of purposeful hourly rounding.
I think the biggest one is we've decreased our falls here by like 60%, I think is the official like rating or whatever.
Good for you.
It also it's a huge patient satisfier to know that someone's checking on you. A lot of times these patients are very scared. They don't completely understand what's going on. And then it gives you a chance to, meet their family, kind of see what's going on. And it just makes sure that they're comfortable. It prevents a lot of miscommunication. It prevents a lot of, even bathroom accidents, making sure that they're getting up and using the toilet, making sure that they don't feel like they're a burden while they're in the hospital. I think I don't have any negatives for it.
Yeah, right? There's no downside.
Yeah.
There's just no downside. Good for you. So let's switch gears here and talk about RNMD rounding. And tell me how that works at Grant Regional.
Okay, so Grant Regional, we do not have a hospitalist here. So all of our providers, I think there's like 8 or 10 providers, follow our patients. And so sometimes it can get really, really tricky when you have 4 patients with 4 different providers following them. So generally I'll pick whoever my most acute patient is. Like if 2 providers are here at the same time and need to round on my patients, I'll pick whoever my most acute patient is and go with that provider. And then generally either our charge nurse or our float nurse or even Dina, our manager, will make sure that there's some RN that goes in with that provider when they go to see those other patients so that the care team stays up to date with us. And then I guess on the weekend we do have a hospitalist, and then we just all take our turn rounding.
Okay, great.
That weekend.
And what benefits have you seen of that?
I would say it really decreases our number of phone calls to providers. It also makes sure that we're, not missing orders, or that we're following through on all of the orders the way that the providers want them followed up on. I think it allows the patient a time to voice their concerns, and then it's an extra set of ears just kind of listening and able to relay that information back to the families as well, because a lot of times the families or caregivers have questions and the patient might not fully remember or understand all the information that the provider's spewing at them. So it gives you a good base of being able to relay that information.
Cool, good, wonderful. And you take care of your business, and so does the physician.
Yeah.
Thank you, Emily. You rock.
Thanks.
Hey, everyone. Here I am again, and I'm with Lynn. Your last name isn't Riesling, is
Rising.
it?
It's Rising.
Rising,
Wish
okay.
It was Riesling. That'd be
Riesling,
pretty cool, wouldn't it?
wine.
Yeah, that'd be really
Absolutely.
cool.
I've always thought of
I'd
you
rather
as
be
Lynn
Chardonnay.
Riesling.
Yeah.
I'm Lynn Chardonnay.
Yeah.
Sounds like a
Yeah.
stage name.
Yep.
But anyway, I was having this great conversation with Lynn during their LDI today. And I said, hey, sister, I'm coming and you're going to teach me how to do bedside handoff. And what I thought we were going to do is how you hand off between departments, because as we know, the OR doesn't doesn't keep people overnight. And so if somebody's going to spend the night in the hospital, you got to take them, to an inpatient apartment. But what Lynn told me, I'm going to explain what you told me about how your department totally took the nursing bundle and made it your own.
Yep. So with the nursing bundle, there was a competency created so that we could all follow along and we could orient our new nurses. So what we did was we just tweaked it to make it more applicable to what we do in the peri-op world. So like I was just saying, our offgoing nurse is really our pre-op nurse who's handing off to the circulator.
Mm-hmm.
So when they do come to get the patient, the nurse who's admitting the patient does the assessment, we document everything, and we have a really nice handoff report in the computer.
Right.
And what they do is we have these two little cards. One is for the OR and one is for endoscopy. So when we're taking a patient to the OR or for their endoscopic procedure, we will fill out all the information, and most of it mirrors what's on the whiteboard. And this follows the patient. It stays with the chart, it stays with the nurse, so that anything that happens in the OR, we can document all those little findings, any of those little important things that we don't want to miss in our handoff report. Obviously, when we take the patient to surgery, it is at the bedside. It's always at the bedside, and we involve the patient because we're also verifying all this information with the patient. Your name, date of birth, and what procedure we're doing, and we ask them this series of questions that we are also reporting off to the circulator is receiving that report from the pre-op nurse. Unfortunately, our patients are asleep when they go to PACU or not awake, and even when they come to phase 2, a lot of times they're sleepy, so the patient's not involved. So it's really nice to have this. We have all this information already at our fingertips. When we take the patient to med-surg, if they are staying overnight, then the little card goes along with them, and we leave that with the nurse that we're handing off to, so that he or she also has all this information.
Love it.
They can carry this along, and
Right.
it's not a part of the chart, but it has a lot of information on it so that we don't forget to mention some of those important things.
It's a tickler. It's a brain tickler.
It is.
So,
It
I
also
love
makes
that.
our handoff more consistent. You have all of these things, it's all consistent. So
right.
that helps. We're
Perfect.
all doing it the same way.
Good.
So
Lynn, thanks so much for that explanation of how you do handoff between your peri-op departments as well as when you take a patient up to med-surg. So Lynn was just saying that, she belongs to a great nursing team called the Ascenders. And so she was part of the nursing leadership team and her staff nurses who bought the nursing bundle to Grant Regional Hospital. But what she noticed as far as skill competency checklists is doesn't always work in peri-op.
exactly.
So what'd you do?
So we took the nursing bundle competency from that's geared more toward med-surg, OB, ER nursing, and then we tweaked it and we made it more appropriate for the perioperative area. For example, one example would be our hourly rounding. A lot of our patients aren't around that long where we don't want to wait an hour to round on them. So our rounding, and it's even more than every half hour. So we are constantly going into the room, checking on them because we really want to get them up and moving and get them going. So that's just one of them. Some of the other things that we talked about, there's obviously medications are the same thing. Our whiteboard also has different information on it than what they would have with than what they would have. I don't know if you can see the whiteboard there.
Yeah, it is different than the one up on the floor. I was just up there.
Yeah, we don't have our name up here, but they do have a little information. And we added like last time they ate, last time they drank, that kind of thing too, that's on there too. But that is part of our world, and those are the things that are important for us.
Sure.
So we did change some of those things, but yeah, we just tweaked it a little bit to make it more appropriate for us, and it was a lot more meaningful, and then it made more sense to our nurses.
You know what? God bless you, child, because instead of just saying the nursing bundle doesn't work for us, it's only for med-surg, you made it yours and made it better.
Exactly.
Case, copy and steal everything.
Yep.
Atta girl.
Yep.
Thank you. Hi, everyone. I'm here live again at Grant Regional Hospital with Amy Bush. And Amy is an RN, driver.
I'm an LPN.
Oh, you're an LPN, sweet. In the outpatient services department, which they just told me everything they do, and it's like 900 things. So thank heavens, all we're going to talk about today is Teach Back. So talk to me about Teach Back. Like, when do you see it as most beneficial?
I think teach back is probably most beneficial before we discharge a patient. We see patients repetitively in our departments quite often.
Okay.
And their situations change throughout their treatments.
So give me an example of when you would see a patient over and over again.
We do a lot of wound care.
Oh, okay.
So
All right.
as their treatments change.
You're their chum.
We see some people 3 times a week.
Okay. All right.
So teach back in that situation is important for at-home dressing changes in between their wound appointments.
Sure.
Or we do a lot of teach back if they have a leaky wound vac, what to do to troubleshoot.
Sure.
We also do a lot of urology work, teaching self-catheterization. And so it's really important that they repeat back to us what to do to make sure they're doing it clean.
Sure.
And prevent an infection. And I think it's also really important to have teach back so that we know the patient understood what we did, why we did it, and how it's to benefit them.
Now, like, you seem very self-assured with, like, I do teach back, like end of story. I hear from nurses a lot that, well, I would, but I don't want to make the patient feel dumb. How do you respond to that?
I think it's important to use lay terms
Sure.
when you're working with a patient and not try to give them a lot of medical jargon to prevent that. And I know my coworkers and we have them repeat back to us so we know they understand and don't feel dumb. And we try to reassure them, some of this we've had to teach ourselves, or we've had to learn or relearn because it's not, you do what you do in nursing. And we're always learning too. So I try to reassure the patient of that.
Yeah, good for you. Well, thank you very much.
Yeah, thank you.
Hi, Kami.
Hi.
This is Jane McLeod live with Kami Doan, who is a registered nurse at the Grant Regional Community Clinic. Did I get it right?
You did.
Woohoo! So you wear many hats, Kami, and they all are equally important, I'm sure. But tell me a little bit about how you decide about post-discharge phone calls, who to call.
So I make phone calls on anybody who is on our med-surg floor, whether they are observation, swing patient, inpatient. So then I will follow up within 24 to 48 hours from their discharge, making a phone call, trying to get that interaction as soon as possible to prevent any readmissions.
All right. Fabulous. I love how you like kind of link it. And there's a huge goal this year for care transitions. So you're a vital part of that. Good for you. So tell me what you asked the patients.
I ask how their first night home was, what questions. We review their medications that they were discharged on. We review the information in their after visit summary. We make sure that the information that I'm finding within their chart and hospitalization notes is cohesive to what they were being educated while they were in the hospital and at their discharge education. Making sure that loop is being closed. All the follow-up appointments are scheduled. Did they get a referral to somewhere? Where do I need to follow up in all aspects, whether it be physical therapy, home health, with a specialist, it's kind of those sorts of follow-ups.
So you actually make those appointments for them?
Usually they are hopefully made before they discharge, but there are times where the patient's gung-ho to get out, or will call back to schedule, making sure that I make contact. We've tried, again, making that appointment to be scheduled. And then if they're not scheduled with a specialist, why not? What pieces do we need to put together to get that referral out the door and follow up with other facilities if needed?
Okay. So the point I want to make here that you said at the very beginning is I work in the clinic and I'm doing the hospital follow-up. In most of hospitals in rural areas of our country, which is our target audience, they own their physician clinics, right? They own their physician practices. So the physician and provider already work for you. Like, why not have the clinic nurse that's going to be doing, kind of overseeing the follow-up on the patient? Make that phone call. I think it's genius. Great work. So what are you challenged by?
Sometimes patients don't answer the phone. They don't call back. Sometimes they're just not taking the initiative to do what they need to at follow-up. They'll say, oh, yep, I know I'm supposed to do that. They're not doing the breathing exercises. They're not checking blood sugars. They're not doing the home exercise programs. So kind of educating the importance as to why they were given those instructions and the importance of doing that to promote their health, to prevent an ER visit, complications, or readmission.
And do you document your phone call anywhere in the medical record?
Yes, I do. I create a telephone encounter with every voicemail that I leave, with every contact made, making sure that I'm making a thorough note so that the provider, when they do come in for their hospital follow-up, hopefully, then they have that closed loop. They know what happened at discharge, what happened in the meantime, and then they're ready for their follow-up.
Perfect. Do you have any stories to tell us of like positive outcomes because of the work you do?
I've had patients, they do give really good reviews, usually when they appreciate the phone call, making sure we are doing that follow-up. You know, maybe they had a question, they weren't quite sure, but now that they're at home, they're overwhelmed with the information. So hearing that they feel comforted and they feel that they know what they're supposed to be doing and educated, and that they're comfortable being at home and not needing the doctor's med surge floor, or the monitors that we do, the frequent checks, they're feeling comfortable at home.
All right, good. They're skilled and competent to care for themselves, and you're a part of it.
Yes.
Atta girl. Thanks, Kami.
Thank you.